Dr. Savaranjan Biswal. He is a professor, Department of Pediatrics, Kalinga Institute of Medical Sciences, Bhubaneswar. He is in Central EB from Odisha 2024. He is also a General Secretary, Odisha State IAP 2021 and 2022. And he has been a EB State IAP for 2008, 9, 2016. He has many national and international publications, and he has a teaching experience of more than 18 years. Welcome, sir. So I request Biswal sir to say a few words before we introduce our speaker and go ahead with the session.
Thank you, Dr. Mukesh. So, good evening all. At the outset, I am very much thankful to Alak Bhandare sir and Mukesh and Anupam sir and all the members of the IAP Delhi for giving me the opportunity to chair this session of the PG clinic in this Wednesday. So, I am it is basically it is for the PG students. It is very much necessary to have the approach the cases judiciously and clinically without less investigation. How can reach the diagnosis? So as it is the time now, we can invite Dr. Nimisha to present the case.
Right. So we have Dr. Dinesh Kaul with us. He's a senior consultant in the Division of Pediatric Infectious Diseases at Institute of Child Health, Sir Gangaram Hospital. Welcome, sir. So please welcome and take over from here, sir.
Thanks a lot. As Dr. Mukesh, Dr. Alok Bhandari already reiterated, this is an initiative which basically we started post-COVID, and it has garnered a lot of support. So with the support from IAP, ICH, and all, so this has become an exercise, a weekly exercise. Primarily, this is meant to teach our postgraduate students the basics of clinical examination and the history taking. So because as examiners, everybody has its own whims and fancies, but as a protocol, we really advise them to follow a particular standard so that they present their case and reach to a conclusive. The idea is to sense their ability to history taking and physical examination primarily. So I would request Dr. Nimisha Basin. She is our second year DNB pediatric trainee at Sir Gangaram Hospital. So she can start her presentation. Over to Dr. Nimisha. I think your volume is a little on the lower side. No, you need to increase your volume. No, I can't hear you, Dr. Nimisha. Go to the volume on your Zoom and make it maximum. Okay, go ahead. No, I can't hear any. I think the connectivity is a little poor.
No, not audible.
No, you're not audible. Are you at home or in the hospital? You're at home. Can you ask anybody to have a login from a different laptop? Yeah, these are unfortunately the glitches of so your speed of the system should be good, the Wi-Fi should be good. So this thing.
Yeah, probably Wi-Fi is good, probably the volume thing is.
Yeah, I think her voice is not audible. I can see her picture, but her clarity of the voice is not there.
So there is volume button in the system also. That can be increased as well as.
Dr. Nimisha, can you hear me? You are muted. Dr. Nimisha, you have muted yourself. Unmute yourself.
Sir, can you hear me?
Yes,
Yes,
now I
yes,
can
yes.
hear you.
Sir.
Yes.
I just
Yes,
need
yes.
to speech.
Good, good. Go back. Go to the first. Start from the first slide. Okay,
Make
good.
it full screen. Full screen. is-
Get a full screen. Yeah, good.
Yeah, yeah.
So I'll be presenting now.
Good.
I'll present me. US, year-old male, resident of Delhi. The informant was mother and the history was reliable. The date of birth is 27 January 2018. The child was admitted on 6th of May and was examined by me on 11th. The child presented to us with the chief complaints of fever for 7 days, decreased oral intake for 7 days, yellowish discoloration of eyes for 3 days, along with yellowish discoloration of urine for 3 days. The child was apparently well 7 days prior to presentation when he developed fever, which was acute in onset, undocumented, intermittent type, associated with chills and drivers, relieved with medication, associated with decreased appetite for 7 days, followed by yellowish discoloration of eyes for 3 days, with yellowish discoloration of urine not involving the genital vein surfaces. There was no history of vomiting, pain abdomen, loose motions, constipation, difficulty swallowing, bleeding per rectum, black stools, clay-colored stools, rash, itching, skin lesions such as petechiae, purpura, echidosis, any cough or breathing difficulty, headache, altered sensorial and sleep disturbances. There are no such similar complaints in the past. There is no history of hospital admission of blood transfusions. There is no history of any drug intake or any indigenous medicine being used. There is a family history of pulmonary tuberculosis in the paternal grandmother, and she has completed ATT course 6 months ago. There is no history of any chronic illness in the family. This is the pedigree chart. The child has been immunized according to the universal immunization program, has not received vaccinations for varicella and hepatitis A. The antenatal period was supervised and unpaid. The dietary history was taken according to the 24-hour recall method and was taking 1,400 kilocalories and 18 grams of protein. The deficit was 12.5% for the calories and 5% for the protein intake. According to the social history, the child comes into the lower middle class category or the modified dysfunction. To summarize, we have a 6-year-old male child immunized appropriate for age according to the universal immunization program, presenting with history of fever for 7 days and yellowish discoloration of eyes and urine for 3 days, with no history of vomiting, rash, loose motions, itching, bleeding, or convulsions.
Stop here and let's try to analyze your, maybe Dr. Biswal can help you out with the each of the.
Okay.
Let's stop here and go back to the history.
Go back to
right
the
from-
initial slide.
Yeah, go to the first slide.
Yeah.
So you have
So
your
there
first
is
slide
fever-
is the demographic slide. So that's the right thing.
Yeah.
Prior to this, what we want you to put the demographic slide. The patient's credentials should be masked so that we don't know his ethnicity, his name. Only his credentials should be sort of as a part of an ethical considerations. They have to be there. Okay, so you have the date of birth with which you can assess the age exactly. The best thing is to say the date of birth. So fortunately, most of us have Aadhaar cards, so it's very easy to get the date of birth checked, verified. Okay, go ahead. Sir. Sir, your comment.
So in this So in this chick complaints, the main thing is fever for 7 days. And decreased oral intake, so loss of appetite is for 7 days. And yellowish disclosure of the eyes for 3 days and dark color urine for 3 days. So there is no other complaint apart from this. No nausea, vomiting, nothing. So vomiting, pain, abdomen, loose motion, constipation. So itching, coughing. So from that complaint on this negative history, what are thinking about patient? What more we can ask?
So we have really looked at this case as a case of fever with jaundice. Fever.
Yeah.
So we will first think of any infective causes because the child is coming with a very acute history of 7 days and the yellowish discoloration is only for 3 days. So we can think of viral causes such as a hepatotropic virus like hepatitis A, B, C, or E. We can think of any bacterial illnesses like enteric fever, salmonella type B, paratype B, any other viruses such as dengue, any protozoal infections such as malaria, that because it's common in North India. We can think of other illnesses such as any drug intake that the child might have taken, which will cause this fever. Along, since it's only a 6-year-old child, we will also have to ask any previous history if this is there, any history of blood transfusions that might be there, any hemolytic anemia that might be presenting right now with acute fever.
There is what are the other causes of jaundice with fever with present acuity? Apart from this, infective causes or any other causes should be included in this.
So we can think of non-infective causes. So we will also have to think of, we've already ruled out drug induced, so we will have to ask about any history of drug intake. If there is a child has taken any indigenous or ayurvedic medication, any isoniazid or rifampicin, history of any hemolytic anemias that might be there, which might have not gotten diagnosed, like hereditary spherocytosis, erythrocytosis, G6PD deficiencies, pyruvate kinase deficiencies that might be there. Then any autoimmune hepatitis that has not gotten diagnosed earlier in the child. We can also think of diseases lower down with disease, but the child is coming with acute history and this doesn't have any neurological symptoms.
So history of drug intake also one of the most important cause you have to take into account. Yes. Apart from other infective conditions which causes this jaundice with fever in 7 days. Other infective conditions apart from this hepatotropic or non-hepatotropic viruses.
Scrub typhus, leptospirosis, leishmania, we can ask.
So simple malaria also one of the most common cause, which may be there. So you have to accordingly you have to explore these things. Malaria, scrub, everything. As it is already 7 days, scrub may be one of the cause also. Leptospirosis. Okay.
Okay, good. So she has already put it in the different. I just wanted to stop her so that she assimilates the basis of history.
Yeah.
So you have the child with icterus, with fever, with yellowish discoloration of eyes, and by the time a child with a malaria would be quite sick in this state. If malaria would be the so the first, as you have, I would not put my finger on the hepatitis B. Hepatitis B is down on the list. So that's a different type of hepatitis C. Most of the time, they may not even know that they are hepatitis C positive. Same way, hepatitis B is in sort of an dormant type of infection which burns out for quite some time. Unless and until child has an acute viremic phase of an hepatitis B, they have fever, arthalgias, myalgias. Then if you pick up in the acute phase, then you might say he has an hepatitis. So the commoner would be an hepatitis A or E in this scenario. Well, in tropical countries, yes, enteric fever should be put a possibility. Malaria should be a possibility. And especially if you have seasonal variation, season is of the dengue season. Consider dengue. Okay. children with leptospirosis will be sicker by the time they have this type of an hepatosplenomegaly. They will be more or less not in the ward, but in the ICU with this type of a presentation. Yes, drug-induced hepatitis should be also kept a possibility. INH toxicity, if they don't tell you that he is on ATT, somebody has started, this child was on ATT and has developed a drug-induced hepatitis, INH-induced hepatitis. So keep that as a possibility. So what thinks you this could be acute cholecystitis or cholangitis?
Even if simple paracetamol toxicity also causes problems.
So provided you exceed the dose. So what would be the dose of an paracetamol which one needs to ingest to have a paracetamol toxicity? So that would be around 100 milligrams per kg per day of paracetamol. So if that is the dose, so he is likely to get, if he takes this for about 48 hours, 72 hours, that child may develop drug-induced hepatitis. Okay, go ahead.
Yes.
So I will now be moving to the general examination. The child is conscious, cooperated, oriented in time, place, and person. The pulse was 120 beats per minute. There was radial synchrony, no radiofemoral delay. It was normal in volume and character. The respiratory rate was 24 cycles per minute. The temperature was 97.6 degrees Fahrenheit as measured in the axilla. Saturation was 99%. The hydration was fair, and the blood pressure was 100 by 60 millimeters. This is the anthropometry. According to the weight for age, the child was 50th, 50th, and the 75th percentile. And according to height, the child was falling on the 19th percentile. On head-to-toe examination, icterus was present at the bulk of the time, seen in natural life. There is no cyanosis, edema, clubbing, lymphedema present, no fatigue, purpura, rash, echinociosis, or a discount. There was tenderness on left scapular palpation and no stigmata of chronic liver disease. On per abdomen examination, all quadrants.
Go slow, go a little bit slow. Go back to the slide, go back to the first slide and go a little slow. Don't rush through your, Go a little slow because your already voice is cracking. So we need to be a little slow. Okay, go ahead.
So should I repeat
Sure.
anthropometry?
Sure. So you have this, you need to have a chart, either whether you are using a WHO chart or you are using an IAP chart or an CDC chart. So whatever is available in your examination center or whatever you have, so you plot, you tell them this is the chart which you have used for plotting height and weight. Okay. Okay, go ahead.
On head-to-toe examination, icterus is present in the bulbar conjunctiva, seen in natural light. There is no cyanosis, edema, clubbing, or lymphedema present. There is no fatigue, purpura, rash, echinociosis, or issue. Tenderness was present on left scapular palpation and no stigmata of chronic liver disease.
Okay, unfortunately, your voice is a little on the, what I will do, I'll read it for you. You can, so because you are, your voice is not really very audible. So,
can you hear me now, sir?
Yeah, little. So what you are trying to look, okay, I'll just help you out with the presentation. So your aim is to go a physical examination from head to the toe. You are looking for anemia, you are looking for icterus, you are looking for cyanosis, for edema, for lymphadenopathy, for purpuric rash, for ecchymosis, okay? And you have found out that there's none of them. Only icterus is there, okay? So icterus is the hallmark. And can you evaluate both icterus and pallor together?
So in not in the conjunctiva, if we have icterus present, we might not be able to tell about palate itself, but we can look at the general skin surfaces and palms to differentiate whether we have icterus along with palate.
Yeah, it's a little dicey situation if you have a deep icterus and the severe pallor to really to substantiate what is what. But that's really where the clinical acumen comes into. And then you have said that there's a tenderness in the left scapula or on palpation. Okay, and you have already looked for evidence of any chronic liver disease stigmata. Okay. Good.
On system examination,
Okay.
on per abdomen inspection, all quadrants are moving equally with respiration. Abdominal distension is present. There is no mass or scar. Umbilicus is central and everted. Hernial orifices are intact. On palpation, the abdomen is soft, non-tender. The abdominal girth is 57 centimeter. The liver has a regular soft inconsistency, smooth surface, non-tender, non-pulsatile, present 9 centimeter below right costal margin in mid-clavicular line moving with respiration. The spleen is enlarged till umbilicus 8 centimeter below costal margin. Regular body, soft inconsistency, splenic notch is it is non-pulsatile. On percussion, shifting dullness is present, fluid thrill is present, and liver span is 13 centimeter. On auscultation, vowel sounds are present. You have to watch this. Should I go with the rest of the systemic examination?
Okay.
So go back.
Go back. Okay.
Yeah. So about the clinical findings, liver, about the you can soft consistency, smooth surface, non-tender, and pulsatile 9 mm costal line. So
non-pulsatile.
So in which condition you will get this soft consistency?
Soft consistency is usually present in either the absence of or in cases of any congestive heart failure, right-sided failures, we might get soft. Firm is more suggestive in cases of malignancies.
It is not properly audible.
Sir, can you hear me now?
Yeah. When do you expect what he wants to, Dr. Biswal wants to know, in which conditions do we get a soft consistency of the liver and which conditions do we get a firm consistency of the liver?
So soft is more suggestive of any acute viral illnesses, any infective causes. In cases of congestive heart failure also we can get a soft liver.
Okay.
Firm is more towards in cases of chronic liver diseases where the liver might have gotten cirrhotic and be nodular.
So cirrhotic livers are firm livers. So if that's the standard teaching, that so you can, this is they are quite really firm, that this is a normal texture of a liver is a soft liver. So it's a more of a sort of an again an ambiguous type of a thing between to differentiate between soft and the firm. But yes, definitely cirrhotic livers are of a different texture. If you feel a lot of cirrhotic livers, you will make out that yes, this is quite different from the normal liver. Okay.
And about the non-tender, whether in case of any infective hepatitis, you get tender or non-tender?
So had there been an abscess, a liver abscess or a bacterial abscess, an amoebic abscess, okay, so you would expect some amount of tenderness, subcostal or an tenderness around below the subcostal region. So that's, you might suspect that this child has an underlying liver abscess. So a child with a firm hepatomegaly with a tenderness, with fever, with very high counts, say 20,000, 30,000 counts, you might think that this child has an underlying abscess. Okay. So that's the sort of a connotation for checking the tenderness of the liver. So is there an underlying infective pathology, an abscess in the liver? Or there might even be some costochondritis. It could be if there's a road traffic accident, there is an injury to the rib, you could feel it is a tender. So you need to elicit the history at the same time. Okay. So everything has to be put in the right perspective. So that's the importance of the history. Okay, go ahead.
So then, it was enlarged kidney
Okay, so again, you are not audible. Your slide says the spleen is enlarged till umbilicus 8 centimeters below the costal margin, regular border, soft consistency, and splenic notch is palpable. Okay. So visibly, obviously, it says the spleen is enlarged. So you need to have 1.5 times the size of the spleen has to get enlarged so that you can feel it, palpate it clinically. Okay. So that's the clinical dictum. So there is hepatomegaly now, there is splenomegaly, which is also non-tender. So had it been a tender splenomegaly, things would be a little different. And you are saying that this is a non-tender type of a soft spleen. And then you have commented about the percussion dullness, about the shifting dullness being present. Okay. And fluid thrill, which is present. And you have commented about the total liver span. So is this liver span normal for this child?
No, sir. According to the age criteria, it is not. It is not. Sir, can you hear my audio?
Is it enlarged?
Yes.
Sir, can you hear my audio? Yes, sir.
Yeah, now you're audible. Good.
Yes, sir. I've changed my device, sir.
Good. That's fine.
Okay, sir. So according to the age criteria, sir, the liver span is increased.
Yes.
Okay, so liver span. So we would expect at this age a liver span of maybe 10 centimeters. Okay.
Yes.
So
sir.
9 to 10 centimeters. So this is definitely an enlarged liver, enlarged spleen. You have ascites. So you have the clinical methods for eliciting the ascitic fluid. So you have said about the shifting dullness. You have said about the fluid thrill. So how much of fluid has to be there in the ascite so that you can clinically elicit a shifting dullness or a fluid thrill?
So for fluid thrill, we require at least 500 ml of at least fluid, sir. 100 to 500 is the range for fluid thrill. Beyond that,
figures are for adults. Is that so?
Fluid thrill is more.
Fluid.
So yeah, for a fluid thrill, more of the 500 ml is the volume for an adult. For a pediatric, I don't know really what are the norms, but fluid thrill for shifting dullness, if you do the puddle sign, if you invert the child or then you can with a minimal, if you are a minimal ascites, then that's how the shifting dullness can be elicited. Okay.
Yes.
So you need to, as clinicians, you need to sort of honor these skills and palpate it again and again. But unfortunately, we have lost with the imaging, with the ultrasound. But most of the examiners emphasize that you should know how to elicit a fluid thrill, how to elicit the shifting dullness. Okay, that's what I want to say.
Usually fluid thrill more than 1 liter like that. $15 more than 500. A puddle size 150 ml.
So fluid thrill, if it is more than, if the volume is more than 500 ml, and for a shifting dullness, if the fluid is more than 1 liter. Okay, this is true for an adult patient. Fine, go ahead.
So I then moved on to the respiratory system examination. There were no positive findings in the respiratory system examination. It was within normal limits. I did inspection, palpation, percussion, and auscultation. And on CVS examination also, it was within normal limits. On central nervous system examination, it was within normal limits. There was no asterixis or tremors present and no signs of hepatic encephalopathy were seen. So to summarize, we have a 6-year-old.
Go back. See, as a pediatric population, we have the liberty because the child may not allow you. 6-year-old child is okay, but a 1-year, 2-year-old child. So you may have your discretion at the ease of the patient, what needs to be examined. So sometimes you may do first auscultation, then you may do percussion. So which is least invasive for the child, you would try to do it first. And then later on, the techniques which will hurt the child or which will be cumbersome for the child, you will do it last. So that's the beauty of the pediatric examination. So you have the ability to juggle between the auscultation and the percussion. So it's not that the textbook, you need to follow that algorithm. So the idea is to elicit the signs with your physical examination. Okay. Same way you may put your stethoscope first. See when the child is quiet in the mother's lap, auscultate him. Then try to discern about the murmur and everything else. You may have to give a pacifier to the child to quieten him, to look for the breath sounds and to do a good CVS examination. Okay, go ahead.
Good evening, Dr. Cole, sir. I just interrupting Dr. Cole, sir. Good evening, Lalit here. And Dr.
Welcome, sir. Welcome.
Just a few points before she summarizes. I think एक slide पीछे करो जो she mentioned that you cannot write CNS like this. Just CNS examination within normal limits. This is not. This is how you learn.
Yeah, this is not this because this is not the. You should mention about the motor, the sensory. You have mentioned. You need to mention about the motor,
sensory, cranial nerve, colon spine, everything.
Yes.
Meningeal science.
So it has to be a proper algorithm. That's what we are here. So you will start with the conscious, the sensorium. But since it is not primarily a CNS case, so that's what. But we wanted the motor, the sensory, you have to mention them in that order about the cranial nerves, about so everything reflects in the CNS examination. Okay.
You cannot on one hand you are writing within normal limits. There are no limits.
That's not the right terminology. Yeah, I do agree with that.
Secondly, in the liver examination, she should mention the upper margin, upper border of the.
Upper border. Basically, we emphasize now on the liver span. So their emphasis is to check the whole liver span and below the subcostal margin. Yes, definitely, as a part of the chest examination, you are supposed to delineate the upper border of the liver so that you decide whether this is an emphysematous chest or a or the liver is being pushed up. So each way it is to be done. Go ahead.
To summarize, this is a 6-year-old male child immunized to date, presenting with history of fever for 7 days with yellowish discoloration for 3 days, presence of icterus on general examination with left scapular tenderness and hepatosplenomegaly with ascites.
Okay, so you have a 6-year-old child with a history of fever for 7 days, the yellowish discoloration of eyes for about 3 days, and then there's icterus, there's an hepatosplenomegaly, and there is a left scapular tenderness. Okay. So what thinks you that this is now really, you have already discussed the differential diagnosis. So if I say this is enteric fever, I don't have the labs available. Okay. I say this is enteric fever, okay, or this is dengue, or if I say this is leptospirosis. So now how do I go with my history and physical examination to substantiate these points?
So one of the important components there, the decrease in appetite were there. So that should be mentioned here. From that also it will give you one of the most important things, fever with loss of appetite.
So
particular-
prodromal features before really he had after the fever, before the yellowish discoloration occurred, so he had loss of appetite, he had maybe a little nauseating feeling, wasn't feeling well, was vomiting out, not having any projectile vomiting, but having a nauseating feeling. So that's really a classical hallmark for an prodromal features of hepatitis before the icterus really sets in. Okay. But for an enteric fever, if you see this enteric fever with a prolonged duration, with this amount of an hepatosplenomegaly, with a short duration, 7 days, I would expect this child would be much toxic. He would be much sick looking. His tongue would be coated. If he has ascites, yes, he may need his vitals are okay. Hemodynamically, he is stable. So enteric children would be a little sicker in this scenario. Same way, dengue children, if they develop icterus, they have dengue, so they may be in dengue hemorrhagic shock. Okay, so that's same way. Leptospirosis, children who have leptospirosis by second week of illness, if they are not treated, they would be much sicker, and the icterus would be definitely. But this is a relatively not that sicker child. Okay. So it looks like that possibly, yes, I would still put the bet on but your labs will tell you what you are dealing with. Okay. So once you order the investigations, so you have to consider your provisional diagnosis. So on that basis, you will order the relevant labs. Go ahead.
Before doing investigation, you should be think about the other DDs or different diagnosis.
Yes, definitely.
Accordingly, we have to go forward.
So, but since he has a fever, so you would definitely order, don't forget to, in this scenario, before you initiate antibiotics, make sure that whatever be the setup, the blood culture should be sent. So sometimes we miss sending blood cultures and we initiate antibiotics. This could have a dual infection. This child could have viral hepatitis and he could subsequently have picked up earlier, he had picked up hepatitis, and from another source, he picked up enteric fever. So we see in tropical areas having a dual infection, both hepatitis A or E with enteric fever. So that should be kept as a possibility. Go ahead. Next.
The child was admitted in ward. Initial investigations were sent and monitoring was done. IV antibiotics were started. Injection cefotaxime was started in view of fever. In view of prolonged INR, which was 1.58, 3 doses of vitamin K were given. These were the initial investigations which had been sent on the day of admission. The hemoglobin.
So why did you start on cefotaxime? So could we have if we are thinking of an enteric, I could have very well started this child on ceftriaxone. So what was the problem with starting on ceftriaxone?
So ceftriaxone in itself also causes some GV edema, and the child already had yellowish discoloration with abdominal distension that we had seen, and we did not know the exact cause of the distension as well as why the.
So how is ceftriaxone excreted? So primarily it's excreted from the bile, from the liver. It's metabolized in the liver. Okay, and subsequently if you have a child with an hepatitis with very high enzymes, so you don't want to further injure unless until you are sure that this is enteric fever. So if you have some outside investigation, say a Vidal positive or a typhidot positive or a blood culture, then very well, yes, ceftriaxone is the drug of choice for treating enteric fever. But if you have to start, if you are thinking that there might be any liver injury, it may not be worthwhile to start on ceftriaxone as an upfront drug. So the better alternative would be a cefotaxime, which has a renal excretion. So it is less hepatotoxic vis-a-vis ceftriaxone. Okay. So you have already given vitamin K because the PT-PTK is prothrombin time is prolonged, and you want to, when would you give plasma? Is there any role of giving plasma in this situation?
If your provisional diagnosis is viral hepatitis, why should you start antibiotic?
First of, yes, why should you start with antibiotics?
If your provisional diagnosis is viral
Yes,
hepatitis.
if your provisional diagnosis, yes, sir, is right, yes, because you had an enteric, you had at the back of the mind, you were thinking that could it be enteric fever? Okay, so that's there's, unless until your labs are available, well, you can right away start directly on just symptomatic, but 1 day, 7 days duration of fever with lot of liver enzymes elevated, okay, which are 400s, 500s, bilirubin elevated. Child, if it is sicker, so it may be prudent to give him a cover of antibiotics till your blood cultures are awaited. Once blood cultures are negative, then very well they can be stopped.
In cases of enteric, usually when if your fever is subsiding and then icterus shows up, that goes more in favor of viral hepatitis. But in this case, the fever was persisting and then yellowish discoloration still occurred. Even though ideally all the features were going in favor of viral hepatitis, before we got a laboratory confirmation, IV antibiotic was started. And once the confirmation came in, the treatment was modified accordingly.
Okay, so we can definitely, as Dr. Saab has said, that we could have avoided using antibiotics in the first place. So it is no harm, and we could wait for, if the child is not already on antibiotics, you have sent a blood culture. But yes, if you are thinking of, say, to avoid fulminant hepatitis, so if you have PT-PTK prolonged, there is icterus is quite high, hepatic enzymes are elevated, you may think of the child may, even in viral hepatitis, to decolonize the gut as a part of, and to you may put them on antibiotics. So it's a little wishy-washy question, but as a protocol, we could have avoided using antibiotics and then later on started them on whatever, if there was suspicion of any enteric fever. Go ahead.
And second thing, when we are approaching any case, we already know the viral hepatitis self-limited disease. So we shouldn't be hurry in seconds, it will be emergency, not like that. So we'll go in a stepwise manner. And before doing, I would done the INR without doing any other investigation, routine investigation like CBC or LFT, whatever may be. That should be done first.
I think the course of listing is a little, she has put it in a different fashion. Go ahead with the other routine investigations, which are more important.
So the initial investigations that were sent were CBC, which showed hemoglobin was 10.4 gram per dl. The CRP was raised, which was 111 milligram per dl. ESR was 115 millimeters per hour. The LFT showed that total bilirubin was 4.8 and direct was 3.6. The SGOT and SGPT were raised, which was 717 and 1072. The LDH was raised, which was 887, and PT, which was 15.4, and INR was 1.48, which I had mentioned initially. It had been 1.48. The KFT was within normal limit. The viral markers were also sent, in which the anti-HAV IgM came out to be positive. The HBsAg was negative. The anti-HEV was negative. Dengue, typhoid, and malaria came out to be negative. Blood culture was sterile, urine and RM and culture was sterile, and gene expert sputum was not negative.
So among these, which are the synthetic function, indicate synthetic function of the liver?
So PT, INR, PT, prothrombin time, which tells us about the synthetic function.
Anything else?
So albumin also tells us about the synthetic function of the.
So what it indicates? Where the synthetic function is deranged or hampered, what it indicates?
Sir, the PTI, the INR was borderline. So it showed that the function was getting deranged, the liver function.
What is the defect? Are the clotting factors thing affected? That's what he wants to say.
There was a coagulation defect because we require vitamin K, which is required for gamma carboxylation of the factors 2, 7, 9, and 10, which is done by the liver. So when we have any disease in the liver, this is the coagulation cascade that gets affected, and hence it shows as prolongation of PT and iron, which is what we are testing by this investigation.
So whether your bilirubin report shows is conjugated or unconjugated bilirubin?
Go back to the LFT. Go back to the, so have a look at the, so what do you say? Total is 4.8. So what is the type of
conjugated?
So when do you call it conjugated? When do you call it unconjugated? So
basically, unconjugated is the bilirubin that is not soluble, and once glucuronidation happens with UDP glucuronide, that is called as conjugated, which becomes the soluble form of bilirubin.
If you're 50% of the fraction, what percentage of fraction of direct bilirubin? Okay. So if you're 50% of the fraction of the direct bilirubin is on the direct bilirubin, so you count it. So what is, it is more than 50%. You are primarily out of 4.8, 3.65 is the direct. So it's more than 50%. Okay. So that's what he wants to know. So you would also look for an hypoalbuminemia. So if you have an hypoalbuminemia, so it had gone to something like 20 total bilirubin and say 16, 17 direct bilirubin, creatinine, so they can get into complications. Later on, he could have gone into an hepatorenal type of an syndrome. This child can get into an hypoalbuminemia. Your calcium is already low, but if you see the corrected calcium, it is okay. Fine. And the synthetic functions, your prothrombin time is elevated, INR is elevated. Okay. So you have to address these issues. So just simple vitamin K, maintaining blood sugar, checking the blood sugar, keeping these children hydrated. Okay. Is there any role of N-acetylcysteine in this scenario?
So not in this case. If the child had showed any features of altered sensorium or had raised ammonia levels, N-acetylcysteine would have helped. But since this is...
Yes. So if this is a paracetamol toxicity with so much of an liver injury, then would be the role of the N-acetylcysteine. Or if this child has developed, is getting into an fulminant hepatic failure as a bridge to his transplant. Okay, so they may have to be put on N-acetylcysteine, which is more or less something a liver hepatoprotectic type of an technique. Okay, a lot of people have put questions into the chat box. So I was just going through, some have put a little doubt about the Wilson's disease. Okay, so any prolonged jaundice, which is more than 15 days, okay, say if a child with a viral hepatitis is getting into a cholestatic phase, okay, and his still L-phos is elevated, gamma GT is elevated, and his icterus is not settling down, it is around 10 or more than you, and the liver is firm, okay, so those children should be evaluated for Wilson's disease. Yes, it's a good question. As this child has been evaluated, so you should evaluate them for a Wilson's disease. So you will get the ceruloplasmin levels and all that stuff, 24-hour urinary copper, and look for the KF rings in the eye. Make sure you do a fundoscopic examination. Okay, so don't forget the fundoscopic examination in this scenario. Okay, a child, don't forget to look at the CNS. A child having a tremor, having an asterixis, having change in the sensorium, may be heading for an encephalopathy. He may need an ICU care. He may be deteriorating. So make sure that this is not always a simple viral hepatitis. They can deteriorate and develop into a fulminant hepatic failure. Go ahead, next.
So how many percentage cases of acute hepatitis A is converted to fulminant hepatitis?
Dr. Nimisha, and Dr. He has a valid question. So What is the incidence of fulminant hepatitis A in hepatitis with patients with hepatitis A?
So I'm not sure about the answer, sir.
You're not sure. It's
Only
about
0.3 to 0.5%.
5.
Not
It's 1 in 1,000. So if you have 1,000 patients of hepatitis A, one child will get into fulminant hepatic failure, which will need aggressive management. Okay, so your tentacles should be really up for children with encephalopathy. So that's how your hepatologists teach you to do the INR off and on for these children and to look for the clinical signs of hepatic encephalopathy. So you have to be, because they may need aggressive management. Okay, so that's very important. 1 in 1,000 approximately is the instance. Okay, so as our center being in center for doing liver transplants, so we are really geared up for looking these children to do the hepatic transplant. Okay, so what about now this scapular tenderness? So this is off the point. The idea was to put this case as a fever with hepatomegaly, splenomegaly with icterus. So it looks like it is a garden variety type of an viral hepatitis, or you could have a discussion on enteric and malaria. But what is this about the tenderness about the left scapula?
Since on examination we had left scapular tenderness, we decided a chest X-ray was done as a preliminary investigation, and on that, the left scapula, there was a lucent area with sclerotic margin that was seen under the glenoid cavity.
By the way, why do we do a chest X-ray in a child with an hepatitis A? What hepatitis, viral hepatitis? Is it required?
So there were two reasons in this child. One, the child had a history of contact with pulmonary tuberculosis just 6 months ago. Second, second of all, in cases of hepatitis, if it later lands up into a complication, sometimes children might develop a hepatopulmonary syndrome, and at that time, symptomatically, we might not be able to differentiate if it is a new onset symptom.
No.
And third, the child also had fever. So to rule out any other cause of fever.
No, if child with a viral hepatitis has ascites, you have clinically said this child has ascites. You would like to see, does he have also an effusion? So the best way, if you are not sure clinically whether he has an effusion, he could have a unilateral or a bilateral reactive effusion as a part of viral hepatitis A or enteric fever as such. So the best way is to do after a clinical examination, do a chest X-ray. So that's why you did a chest X-ray, and surprisingly, you found out a lesion in the left scapula. So now you are chasing this. The story changes, okay? He has viral hepatitis, possibly hepatitis A or E, but what about this sclerotic lesion with a hypo-intense lesion on the chest X-ray? So the infraglenoid region of the scapula is involved. So you can't really. So what do you think? Could it be TB, which we have missed? Possibly. The child is not having fever subsequently. He didn't have fever earlier prior to a week. He didn't have any complaints of there being any trauma or anything like that. So what do we do about this?
So this was the baseline ultrasound that was done, which showed that the liver scan was 14.1. The spleen was grossly enlarged with 10.8 centimeter. The hepatic veins were normal and the GP was thick with edematous wall. For the scapular lesion, we got an MRI, which was suggestive of a lytic lesion in the left scapula in the infraglenoid area, which was rim enhancing, soft tissue showing anterior extraosseous extension with intramedullary lesion in the inferior corner of the scapula. Up to 1 centimeter medial sinus lymph nodes were also seen.
Okay. So you have mediastinal, you have a sclerotic lesion, you have a soft tissue, something like, it looks like it might be a cold abscess. Okay. So what do we do about it? So how would you coach such a child?
So there was This is the treatment that is I've written for acute viral hepatitis, sir. But for the lesion in itself, drainage was done, tapping was done, and that sampling was sent for the tissue sample was sent for gene expert, as well as to see if that was a cold abscess that was lying, which currently under process has come out to be negative.
Okay.
So we did not start the child of any anti-tubercular therapy, but since the child did show us a lytic lesion, we did give clindamycin was started. And the child has been afebrile for over 72 hours, has been showing gradual improvement, and our repeat investigations were sent.
Okay, so we don't know really whether the settling down of the fever is as a part of the normal convalescent phase of hepatitis, or you have started antibiotics, there was a pyogenic abscess. Okay, so initially also prior to the fever was not very high grade spiky fever. So this is definitely needs further evaluation whether this is a bacterial abscess, since this is not possibly a tubercular abscess. So you are waiting for the FNAC report. If the FNAC is not conclusive, you may have to, because he has developed an osteomyelitis of the scapula. You don't want the scapula to get destroyed. So he may need some orthopedic intervention, an incision and drainage or curettage of the local cavity by a trained orthopedic scapular surgeon, shoulder surgeon. So that's what will be done. Any questions, sir? Dr. Biswas, Dr. Mandirata, you want to put your comments?
Basically, if without any primary lesion, how can you suspect tubercular of the scapula in this child?
So that without the Mantoux, so you need to do a Mantoux testing for this child. There you need to ask the family history of contact. So if there is a history of contact of TB in a family, so chances are that a cold abscess sitting there, which was not really symptomatic earlier prior to onset of viral hepatitis, could be possibly a tubercular abscess. So that's what would be our first, that's a cold abscess. So it's unlikely to for the scapula and that to an infraglenoid region to have a tuberculosis of the, but you can have surprise. Oh, but FNAC has not revealed any evidence of an TB. The gene expert is negative. The FNAC is not showing any evidence of a granulomatous lesion. So possibly there are a lot of histiocytes sheets, which is a more of a chronic inflammatory process. Possibly this is a bacterial infection. So this needs to be treated with antibiotics. So we cannot leave this as such. It has to be treated with osteomyelitis and it needs an orthopedic intervention.
And one more thing here, it is in this case, this child with viral hepatitis did not have so much of splenomegaly, you know.
Yes, that's very important. So
that is very, very important. And ascites as such in acute viral hepatitis, unless the child has gone into failure, is not seen, right?
Now, over the time, it has settled. His liver size has settled. His spleen has settled. His ascites has settled. So that's all the more reason, if a child is having hepatosplenomegaly with ascites, you should rule out TB. TB is still the #1 leading cause of infection in an Indian scenario. So TB would be very high on the cards, but we cannot start ATT empirically, what we used to do 20 years back. So we need to have a documentation.
Definitely, we need to have another etiology apart from hepatitis A in this case, because many things are not explainable on the findings.
Yeah, it looks like that. This is he has a dual pathology. He is recovering from hepatitis A. He has picked up hepatitis A. His serological markers have come positive for A. His rest of the infective markers for typhoid, blood culture, Vidal, everything is negative. His Mantoux is negative. Okay, so this possibly the scapular lesion may be a pyogenic abscess, which needs further evaluation. So he is not immunodeficient because he has been evaluated for such children should be under. Why did he get the abscess? That too at the scapular lesion. So you should investigate these children for underlying immunodeficiency.
Yes, thank you, sir.
Any more inputs, sir, Dr. Biswal?
Usually in hepatitis, the splenomegaly very rarely seen. And this huge splenomegaly in this case
Yes.
is not giving any explanation
Feature of
what
hepatitis A.
Yeah. So that's why it is maybe any other condition as to with this.
Yeah.
We have to
See, had he leptospirosis, had he scrub typhus, he would not have settled with just clindamycin, or now he is afebrile. His liver, spleen has settled down, and the ascites has settled down. So it looks like he is in a convalescent phase of hepatitis, and he has one more etiology, that there's an abscess sitting down, which needs to be evaluated. Maybe you can have, unfortunately, the pyogenic cultures which have been sent from the ultrasound guided aspiration are negative. So any question for the candidate, because this is for their what they need, what they have missed in the clinical examination or in the physical examination.
And one more thing, when you were specifically telling that left scapular tenderness, this does not signify something. Just describe the complete examination. On inspection, where was the tenderness? Was there any swelling there or not?
Yes.
But the movement towards scapula were normal or not? It is just scapular tenderness. Scapula is a big.
You need to see that whether there was a collection. Yes, she needs to delineate if you have mentioned about the there is, so you need to mention the candidate name, whether there is any swelling, if there is any bulge in the scapula. Then you need to come to the specific, whether there is any tenderness, and if there is a swelling, what type of swelling it is. The way surgical residents are trained to look for the different swellings. So that's a valid point.
Because tenderness of a scapula does not indicate anything. Scapula is a big bone. You have to mention the complete clinical examination.
Yes, that's very important. So somebody has put a question about the biliary sludge. Yes, if there is biliary sludge, if there is cholecystitis, there is a prolonged cholestatic phase. So you might get a biliary sludge. If there is use of ceftriaxone for prolonged time, you may get biliary sludge. Somebody has put a little question about the late onset cholecystitis. So late onset children with viral hepatitis may also get a little bit of an cholecystitis. Yes. Was he going into an acute liver failure? Unlikely. His PT-PTK has settled down. He has not deteriorated. But his albumin has been okay. So then again, somebody has questioned about the splenomegaly in hepatitis A infection. You can get hepatosplenomegaly, but not to this extent in hep. So you could get in complicated enteric fevers. Okay, but his Vidal blood culture is negative, so unlikely he doesn't have enteric fever. And say what is somebody has put okay, I can't. Okay, I think somebody has looked at the HIV. Yes, HIV is one condition you should, for such children, you may like to do an HIV testing. So that's the protocol, what we do. Somebody has put about the Ixol. So his sensorium is normal. There is no cerebellar involved, any raised headache, vomiting. So Ixol would be unlikely. Somebody put has about the liver mass. Yes, there could be a liver mass. Could he have a tumor? Could he have a primary liver tumor presenting with an hepatitis? But such a short duration history with fever and all that. But yes, that should be. I'm not sure this would not be the age for an hepatoblastoma or something like that. Wilson's we have already discussed. Sickle cell and thal. Yes, one condition which we mentioned in this, any children with E-beta thalassemia should be really, this can be a precipitating factor that for the first time you're picking a child who has an E-beta thalassemia, a viral hepatitis could precipitate them. So if they have evidence of hemolysis on the peripheral smear, okay, so if the hemoglobin has dropped, say 6, 7, there is evidence of hemolysis, there is no G6PD deficiency, look for an hemolytic anemias like sickle cell anemia or thalassemia. Somebody has commented about 200 milligram per kg. I don't know whether is the dose for the cefotaxime, but for this condition, the enteric dose for cefotaxime is just 100 milligram per kg per day. 200 milligram per kg is the anti-meningitic dose. And again, somebody has commented on the left tenderness scapula. Is that so important? Yes, this is just a coincidental finding which the candidate has put in retrospective after seeing the ultrasound and the MRI report. And clinically, the parents did not come with the complaints of the left scapula, this thing. Pyogenic abscess, well taken, that you should really look for if you have a tender hepatomegaly, pyogenic abscess is a possibility. Splenic notch is only felt by HODs. Well, he has put a valid point. Splenic notch is, yes, you need to, I will beautifully see you the splenic notch in thalassemics who have massive splenomegaly. So we mark their spleens and can show you the splenic notches. Mild splenomegaly, you will not see the splenic notch. I will take it, well appreciated. Somebody has commented about the fluid filled is very difficult to palpate. Yeah, there's a technique called a dipping method. So obese patients, massive fluid. So you do a dipping method to palpate the liver with a massive ascites. That's the technique. Dengue with secondary HLH. Yes, these children it is a possibility in dengue season. Yes, secondary HLH can be, but they are sicker children. Okay, so that should be definitely a possibility for sicker children. Wheals disease, wheel flexus disease. Yes, tropical environment. We have to keep it as a possibility. Okay, again, this is the same about the voice cefotaxime. We have answered biliary sludge. Late onset cholecystitis as a part of viral hepatitis. Would amoxicillin suffice? Yes, amoxicillin possibly would have sufficed as an OPD if this is an ambulatory patient. But if you are thinking of enteric fever, sick child admitted in the hospital, you may well want to start on IV antibiotics. And he is not going into an ALF. I think I have discussed most of the queries. If I have missed, I'm sorry. I think we close it over here. Any further questions? You are most welcome to put them in the chat box. We can email you separately.
So I think we can close the session if no more questions. So thank you, Nimisha and Dr. Cole, sir. Thank you. Mukesh is there?
No, I think Dr. Mukesh has said that he needs to take an emergency call.
Okay. Then okay, let me give the vote of thanks from IAP. Thank
sir,
you,
Sir, आप भी दे दो, मैं भी दे दूंगा.
Dr. Mehdi Ratta is there. Sorry, I missed it.
नहीं sir. Dr. Lalit, go ahead. I would really love to hear from you.
Mukesh, आप vote of thanks दे दो.
नहीं sir, I would really love.
Acha, okay, thank you, Mukesh, from the IAP Delhi side, and Nimisha, wonderful presentation. I think you come to know where you are next time.
In spite of our audio and all that, we try to help you out with but next time we think we should have a better connectivity, okay? Because we miss the technical aspect of the presentation. Thanks, Dr. Nimisha. I appreciate the efforts you have put in. Thank you.
Thank you, sir.
Sir, we really must thank Dr. Biswal, sir, for being with us for all this time, and we are really thankful that you agreed to be part of us, Delhi IAP. We are thankful from the core of our hearts, sir. Biswal,
Thank you.
Thank you, Dr. Thank you, Cole.
And thank you, sir. Thank you, Dinesh sir. And thank you, Dr. Nimisha.
We can close.
Wonderful presentation.
Thank you.
Right.